Okay, so next case, we have a 70-year-old gentleman, known diabetic, hypertensive, recent inferior wall MI, now who has effort angina class 3 with good LV function. His angio shows RCA 70% lesion in the proximal part. LED shows significant 90% lesion in the mid part, and major OM shows 90% lesion. Watch live now.
Hey. You guys see the picture?
Yeah, we saw the pictures. So just tell us about your access here and your strategy.
Access is a radio access. You can see it's a regular radio, 6 French slender. The guide catheter I use is a JL 3.5 side on, and with the telescope multi-purpose in. Okay, I like this approach of telescope. How many of you using the telescope approach? A micro multi-purpose inside of the guiding catheter?
You go. I can say selectively, but not uniformly is my practice. Maybe I'll ask our colleagues on the other side how often they use the telescoping approach.
Not very often.
Not very often.
Tak, why are you using actually telescopic with the 6 French?
Nearby.
Why? I think they tell the truth.
If you use long sheet, then you won't have to use it.
In my practice, I did not do that.
Tak, there was no need for you to answer that because Tejas basically wanted to make the statement that he normally uses a long sheath. So now he was restrained yesterday. He's mentioned it 3 times today.
Tejan's always long sheet, right?
Okay.
But Tejan needs to also know that he's not alone. I'm also a long sheath user.
How about on this note, we ask our colleagues, are you long sheath, short sheath, any preference, any reason from a radial access?
I don't use too often long sheath. I use a short sheath only. But only thing is, if it is a long sheath, it's advantageous. You can use
1 foot, 1 foot.
The spasm may be much less, and then you can repeatedly change the catheters if you have got a multi-vessel intervention.
Epicranial yellow.
Sam, do you want to comment on this? I know you used to say that the less you even have your short sheath hanging out from the wrist. Is that still the case?
Yes, so sheath causes a fair amount of trauma going in.
Which one?
And so if you're using one catheter, then there's probably not a big advantage. There might be drawback.
Okay. So let's do that.
If you're doing a lot of exchanges, then obviously there's an advantage.
This is BMW. Run.
Sam, why do you think actually sheath causes trauma? You don't think catheter will cause a trauma?
Okay.
Sheath is usually two sizes bigger than the same size guide catheter, So if you introduce a 6 sheath, it's like putting an 8 guide, and so you have to weigh the options. But a lot of times, even the entire 11 centimeter sheath doesn't always go in without resistance.
All right. So the guys engaged in LED. There's a very short left main. So I think I do the LED first. You can see there's a lot of ulcerated plaque in the proximal LED, and followed by a tight diagonal, about 2 O vessel. Then LED, the lesion is 90%. Distal some irregularity. I will not worry about that. So I think I only treat the proximal LED after the diagonal, and I like to widen the diagonal so to protect it. What do you guys think the strategy?
To me, that sounds like a really good strategy, Tak, but maybe we can have some other comments from the panel here. So you're going with a balloon and stent, no atherectomy, is that right?
No, yes, correct.
Okay.
That is
so comments from Bangladeshi
so you
section.
You think a lot of calcium?
Just wondering about that. Here we go. We're just going to have some comments from our panelists here.
Again, your question, please.
So the strategy, I think, TAC, is that you're going to do a limited length of balloon and stenting with a protective diagonal wire.
Correct.
So we just comments on limited versus longer stenting.
Okay, so let's get diagonal. Can I get another wire?
Yeah.
And while we're just waiting, so your choice was a JL35 guide, not an extra backup guide?
Yep. What do you guys think about the guide selection?
It's okay.
Yeah.
I mean, the answer is it looks beautiful right now. The question is, are you going to regret it when you try with stent delivery? Just as a sort of side comment here, we spoke briefly yesterday about guide extension catheters.
Yeah.
It really has made our life easier. So if you go with a less supportive guide, you have an option to increase your support with the guide extension. Do you think that's a reasonable statement?
I think it's very reasonable. Where's John? John Coppola here?
Yeah.
Right. I know you're using all JLV5 guide for the left intervention. Is it true, right? Is it true?
I actually am using the EBU 3.5 more and more often, but I will use the JL. And as Rajee said, you know, the guideliner has saved me on many occasions.
Okay.
You know, it's made
That's it.
complex cases
Now I
a
need
lot
a balloon.
easier, it made delivery of stents a lot
So let's
easier.
just
Balloon on LED?
balloon on LED. Let me ask the panel decision or John's decision. Now I write a diagonal. You think I need to balloon the diagonal or just leave it alone? Or just keep it open? What do you think, John? The diagonal is a very tight lesion there.
I think we can just leave the wire there and we can work on the LED.
Work on the LED, yes. I believe this is my strategy too. And the LED, what balloon I should be dilated? Everyone agree with I should be dilated, right?
I think so.
Absolutely.
What balloon? Any suggestion?
I think you can take 2.5 non-compliant balloon, probably 2.515, and then you can dilate proximally. I think then we can work on that.
I agree with you. 2.515?
Yeah.
Non-compliant.
2.5
No, leaning forward to P-dilated with a non-compliant nowadays, or everyone's still using compliant balloon?
If it is calcified vessel, I would not even go with 2.5, I would go with 2.0. The reason we use non-compliant balloon, in case if you need it, you need to go to higher pressure, right?
But this vessel is not a 2.0 vessel.
I understand.
It's still
but
not 2.5 vessel.
all you are trying to do to get the track, to get the stent in.
I don't know true or not. I think we get some better lumen.
Let's say if put 2.5, how high pressure you will go there?
14, 16.
And if still doesn't crack, then what you do?
Go. Okay.
I think you would burr it if it didn't crack.
Yep, go up. We can burr.
Even we can try a scoring balloon and then we can try it out there.
14,
If it, is,
15,
it doesn't work.
15.
We
You
do
know, I have
15
tried
atmosphere.
to a balloon up to 30 atmosphere and it cracks any actually lesion without rupturing balloon.
Or arteries?
Any
Test them.
calcified artery.
Okay, do it here. One.
It's a great discussion, and just to note, there is some new technology coming that many people may be aware or unaware of, the lithotripsy balloon, and also the super high pressure balloon from SIS Medical. You can take to 40, 45 atmospheres, typically for post-dilation, not pre-dilation, but those numbers make you nervous, but some of the success rates have been successes have been quite impressive. Anyone on the panel here had an opportunity to see or use the lithotripsy balloon or these super high pressure balloons?
No, I don't have the experience. What's a lithotripsy balloon? What do you make of? Just a non-compliant or some other material or some?
No, you deliver lithotripsy, like fracturing the kidney stones through the balloon.
That's a sound wave, ultrasound.
Yeah, I don't know that don't know the exact frequency, but absolutely, it's an energy delivery balloon catheter.
Yeah, it's a low frequency oscillation. It's actually a pretty smart concept. It breaks up the adventitial and medial calcium more than intimal, which is what rotablator doesn't do.
Okay.
So many of us do get faced with this issue, and the question comes up, do you
Okay.
go to high pressure with your non-compliant balloon to the point where you've cracked it or maybe dissected the vessel? The other option is,
No.
some people would
It's a
take as
3-0.
well,
John, what do you think?
they can get a stent in, and
3-0,
now they'll
30,
feel safer
30,
going up, but now you've got
3-0,
the risk
right?
of leaving
3-0.
an underexpanded
330
stent. So Rajiv and Tejan, the other members of the panel, what are your thoughts here? Do you make sure that the lesion is adequately prepared for the stent, or do you wait until you put the stent in? Really important
I'm putting
question,
a stent
particularly for
now.
a young cardiologist.
I'm going to stand you.
Prepare.
I think prepare is actually ideal situation, but while you're trying about preparing this, most of the time,
What
you
kind
do
of
not
stent
take
we're
the
putting?
burr size.
Honest?
You do not take the burr size up to the optimal level,
Synergy.
particularly if you with the 6 French guide in it, you have a limitation up to 1.75. And if you are burring vessel at 1.75, after that you
332.
post dilate
32.
that,
32.
or even if you crack that lesion at 2 millimeter at high pressure, with the drug-eluting stent, I think we can get away without much issue because of restenosis issue. It's very rare unless it's a big vessel. If it is up to 3 millimeter vessel, once you crack that, I think you can expand it. If it doesn't expand, you can post-dilate at high pressure also. And we will see with this new trial where stent deployment is up to 26 atmosphere now coming up.
How about our
I think you
colleagues?
can take up
Hyper
non-compliant
base by
balloon
big
to
person can-
go to, you make it 1:1 and then you can try to crack it up and prepare the bed well. Suppose if it doesn't yield and then it bursts, then I think it makes sense to take a scoring balloon. Angiosculp is a great option for us, not the cutting balloon. Angiosculp scoring balloon is a very good option which tracks well, and then we can prepare where the junction is. If you do a left main LID circumflex bifurcation, that area can be modified, the block can be modified very well with the angiosculp. You can take a 3 millimeter, 3010 or 3015, and then you can prepare it well. Then your stent expands very well without effort. I think preparation is very important, and then if you are shy of rota, then you have to have the low threshold for the angiosculp.
Going up.
Yeah, going up.
This is a case of calcified lesion, so rota ablation is ideally better for this case.
14.
14.
So I think already we can see there's a segment there that the stent is going to be underexpanded,
Yep.
certainly relative to the remainder of the stent. So it's going to be very interesting to see what the strategy is going to be employed to deal with that.
And I totally agree. And just maybe a related comment with going back to the laser, just a reminder that the laser is seeing a resurgence in the treatment of underexpanded stents. Now with laser bomb or laser and contrast, you can fracture the calcium external to the stent and then that expand the stents properly. That's certainly been a resurrection of laser technology, but it doesn't always work. And I think when we can't rely on that as a guaranteed expansion of an underexpanded stent, but it's a good backup to have in your treatment algorithms. Malcolm, and you didn't answer your own question. Are you a preparer or a stenter, and fingers crossed?
I'm a preparer,
Look nice.
and but I've learned that the hard way.
Okay, so we need
And
to balloon the middle part, the unexpanded stent, we need to balloon.
The curve.
Yeah, using the high pressure balloon with a 325, we had a 3256.
Yeah.
And
3.56
Tuck, what
or
pressure are you
8.6?
prepared to go to?
You want NC?
NC.
Yeah.
I hope we can do in a 16, 18 to open up.
What
do you think?
What size is stent that? Diameter?
The stents are 30.
3032. Synergy.
So are you using 3256? What do you think?
I would actually use 30, 12 or something like that, 15, and you can then go at very high pressure if you have to, 20, 20 plus.
So what's wrong with 325 then?
I think high pressure, you're going to have a little bit difficult time.
Really?
But you know, I think when we
If
do
you-
these, when
If
we
we have to go,
sorry, go.
If you have to go more than 20 atmosphere, I kind of undersize it. At least you want to just expand that stent,
I hope
not the rupture.
But I think the choice of stent length is also very, balloon length is also very important here. So we would generally try to use a 6 millimeter or 8 millimeter at the most for such a segment, because you will be able to really focus that pressure at that point. If you use a longer balloon, you're going to give some give at the other ends of the balloon, and you won't get the pressure really focused and distributed in the right spot.
Yeah.
That's
I think
correct.
shorter balloon, short NC balloon, the pressure is much better than the long one. So I think 6 or 8 millimeters are perfect.
Yes.
What do you think?
I mean, the larger diameter is going to give you more radial stretch by the plastic block.
So Ted, do you have a 6 millimeter balloon there to use?
They don't. Now they found an 8. 308 is fine. Okay?
Fine.
308. It's an NC, right?
Yeah.
Okay. So it's a 308 here.
Now, Ted, are you going to do a POTS on the approximate portion?
Yes.
There are
Would you
Apollo
leave
balloons which can go up to 30 atmosphere, it will take actually. They can crack it actually.
Wow, you guys are little bit sub-optimistic.
When will you remove that? When will you remove
Tak,
the
are you
larger
going to
diameter?
dilate that at the side branch wire or just below?
We are just below. I just want to do the unexpanded part first. Then I will part a little bit in the proximal part. Then I take out my gel wire out. So far I have flow in the diagonal, so I'm not go after the lesion in the diagonal.
Let me ask you this. Let me ask you this. Why actually on that dial you have up to 30 atmosphere?
Why is what? 30 atmosphere?
Yeah, see that on the dial?
Okay.
No, indeflator dial.
Just
Okay,
good.
go.
Going up.
Tuck, on the angiographic image, the last one we saw,
40.
was there still a dissection on the inferior part, in the more proximal part of the stent?
I don't think so.
Okay.
What, this is 18 now? Get 20? I think the calcium on the other side,
Is it, yeah,
down.
I can see the calcium. I just wondered whether there, maybe it was a branch or something. I was
Let me
wondering if there was a
take a picture.
focal dissection that was still
Where?
visible
Let me
outside the
Okay,
stent.
let's see that.
It was more proximal.
This look nice.
Where is the dissection? I don't see that.
It
well in my
may have been a
view.
branch then.
What is
I
the,
think it's a branch coming out, right?
I think so.
Well, how about the expansion of stent? Are you guys happy?
Yeah, it looks as though it's improved.
Yep. I don't think I can make it perfect because the calcium is really on the other side. I go to 18 atmosphere. Looks okay here.
So I guess this is a really important question. I mean, it looks as though there's been some improvement.
Yep.
So now the question is, do you want perfection or do you not want perfection?
I don't want perfection. You know what I mean, right?
Better
The enemy of blah 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 is perfection. Okay, so
We're with you.
I'd like to do a little bit part. You have a 325? No, you don't have 325 balloon. So give me 35 balloon.
Okay.
3512. You have that?
358.
8 is fine. Okay. 358.
3.58.
You guys agree always part before the bifurcation, or you just take it as it is?
With this calcified vessel, are you worried about removing a diagonal wire, or do you think the POTS is going to make that easier?
Yes, 358, correct. No, yeah, if there's a long overlap, I will worry about that. But if a short overlap, the proximal part very short, should not be a problem. And remember, I put a specific as a run through right, going to diagonal. So the run through, there's some coating. So more slippy to going out.
So Tuck and John, you're both very experienced interventionalists. How many times in your career have you had a trapped guide wire?
I could only
Tell
think
you
about
true.
one time that I had to help a junior colleague get a wire out by putting in a small balloon right to the tip, and then at that point it was easy to pull it out.
You're always putting it out if you put a small balloon or something, or microcatheter to support it.
I think that Matthew just called you old. He said very experienced, but he meant that you were old, Tech.
You know, this morning he asked me how old I am. I said I'm older than him.
Wait on, I did not ask you that question.
That's a test.
Rajiv asked you that question.
I would say I have not done enough intervention.
Do you guys agree this is a good part position? Let's go.
It looks good. And Tak, I'm surprised you remember the question.
I know. My eyesight is not that good, you can tell. 14.
40.
Yeah, 14 and a half, a little bit more.
But the question about trap wires, I think, is an important one. It still occasionally happens. We see it at complications meetings, and when there's calcification and multiple stent layers, they're the two principal risk factors and would make me nervous. I think with a single stent here, the chance of a major problem is relatively low.
Rajiv, do you have any opinion on whether it should be a hydrophilic wire or a non-hydrophilic wire? And maybe some comments from others here.
Yeah, that's a great question. I used to have an opinion, and my opinion has changed. The initial teaching used to be avoid a polymer jacketed wire as a jailed wire because you can strip the coating when you pull the wire off. But I think we saw a real nice paper in Eurointervention a year or so ago that shows that's not the case. In fact, there's more damage and loss of coating in the non-hydrophilic wire than there is in the hydrophilic wire. So they were reversing the thinking. They're saying maybe you should actually, if you're going to jail, use a hydrophilic wire in the side branch. Any comments from our panelists or other colleagues?
I agree with you, Rajiv. Actually, I used to put choice PT wire. They just talked me out of it. I have gone back to choice PT
the jail wire, just make
because
sure my guy is not sucking in.
yeah.
And this one is not that bad. You can see that it's removed. Of course, don't do it crazy. Okay.
So I
think
have
we're
gone
okay
back
now.
to choice PT wire. The reason actually I looked at it, and even with surgical blade, when you try to
Not get a quarter.
snare that wire, nothing
Yeah,
happens.
Epicaudal.
So I just put choice PT wire now in.
Is that because you use a long sheath?
Okay, good. Ready?
Yes, I was asking about the jail balloon techniques, or anyone do you do, Dr. Saito has shown modified jail balloon techniques in last Asia PCI.
All right, now I think the LED, I finish it. I don't think I will do it anymore. Now I go into the circumflex. This patient is short left main, so I need to I stabilize the guy in the LED. The diagonal wire, which I just took out, I will flop into the circ. So let's see. We had the same balloon, 2.5 balloon here.
Tak, I drew your attention to a possible dissection in the proximal LAD, and I think you convinced me that there wasn't. On your last injection here, is there any possibility that there's a small left main dissection on the superior aspect?
I suspected so. Actually, you have to pay attention to that because even I thought there is a linear dissection on the ostium of left main.
I would take another picture to see.
Do you want a picture?
Now let me take my guy out slightly, and then because they were dissection, so I want to make sure it's not
So I think as Tak is doing this, again, I think the young cardiologists really need to pay attention to his technique here.
Okay, go. Let's go.
We don't see that in this.
The left wing really short. I don't see it at this moment. I'm going to reassess later after I finish the set. Okay, how about that? Okay, give me the sample.
Just remember that.
Yep.
2.5.
No, absolutely. We pay a lot of attention to the hemodynamic EKG when we do the case. So far it's good, right, John? John have a better eye than me.
No, the hemodynamics and EKG have been rock stable. But I saw what Malcolm was talking about on the AP caudal shot before this. They look to be like a linear contrast.
So we will
I think when you do your OCT from the LED back, you might take time to look at that left main.
But it's not a good idea, right? OCT for left main, you said, Dr.
Well, I think
Akas?
the ostium in the left main is not a good idea because you have to be well engaged, right? I think you could see that proximal portion of left main.
Yeah.
Okay,
Yes, perfect.
let's go. So this is SAM25 balloon we use. It is on. You open well. So I will pull the balloon back. Now since the guy, I need to manage the guy very good now. So make sure it won't causing any damage. Okay, take a picture, please. Now I see the left main is did not see the left main well because it's a short left main and the circumflex lesion. Yes, please.
Caudal.
So circ is a 3016.
Just check it. Take a picture.
Okay, ready?
Yes. This is the better. 18?
Yeah, 18.
3018.
My teaching is that the circumflex usually is not oversized. I like to undersize slightly the circumflex. Is still true in nowadays?
I think the circumflex is magnified angiographically because it's further away from the
correct. I think
back panel, so more of a magnification.
I think that's important for some new young fellow to know the circumflex is magnified a little bit compared to LED RCA.
Yes.
3080?
Yeah.
Okay.
Can't get to use the biotronic stent. We don't have this in the United
Oh,
States.
okay, nice. There's a same stand using the
Orcido from Biotronics.
using the noble child, the left main child, right?
Okay.
Picture.
It's perfect.
Go in a bit. Yeah, go in a bit, right? When we go. Go. Okay.
Okay.
Go.
Stand.
Go, Charles. Yes.
Down.
Someone touched me needed 45 seconds, but I think I'm okay. Go down. Is a Mauricio there? Okay. Ready?
Okay. It's good.
Okay. I think time to OCT. What do you guys think?
The proximal part of the stent has not come up that great compared to the distal one. But
the proximal part? Let's see. I forgot where I covered.
You want to dilate with a non-compliant balloon, proximal portion?
We had the free,
non-compliant.
We had that. Using same balloon, we try to save some money.
Yeah, take the 3 or non-compliant to the proximal portion of that stent.
Yep. Still the RCA need to be done. Sorry to hold you guys for lunch, but
Little back.
okay, good, go.
Is it 12?
40, 16.
16.
Okay, done. 16 done. Picture. I think I'll leave alone. Okay. So let's get an OCT for the LED.
At least the panelists sitting alongside me think that this looks very good.
Yes, wow, boy.
No?
Yeah.
Taka, this is looking great, and with the JL35 has not been any problem at all for delivering stents into the circumflex.
Yeah.
Tell me, just yourself and maybe the panel, strategies of dealing with short left main. That can be a challenge sometimes, maybe more so from the radial because you have less perfect control of the guide tip. So like an EBU here, could well be deeply engaged into the LAD, but your JL is perfect. So what's your strategy for short left mains and right transradial approach?
John, you have any idea? You're using more juggling.
I tend to do with TASCOs. I tend to
we see it.
wire one of the vessels, whichever one I'm selectively in, and then work on that vessel and then just use that wire to back my guide out and allow me to slip into the other vessel. So there are times when I'm doing a circ where I would wire the LAD and use that wire as a support to be able to back my guide out enough to be able to drop the wire into the circ.
Yeah.
And on a short left main, I still end up using an EBU.
Wow.
Yeah, 100% agree. I think that's a great tip to use the support of a wire in your non-target vessel to manipulate another wire into the target vessel.
Yeah. This is an excellent tips for short left main.
So a question for the people in the cath lab room and here for the panelists. Many people using the Akari guides?
Akari?
Yes.
Not I.
We use it only for difficult situation, Akari actually. If the routine stuff doesn't work, particularly when there is a tortuous subclavian, we have tried for the Akari. Akari left works well with the Akari on the right side, RCA intervention too. It gives a good support. And particularly this tortuous, many guides fail to engage, Akari does.
Yeah, I've been really very pleased with the Akari guide. So for anything that looks slightly difficult for the right, I found the Akari 1 or 1.5 has been very, very good, very supportive, easy to engage. The advantage I think with the Akari lefts, particularly for the LAD, is they're very easy guides to engage, and they usually give you very good support for pretty much everything except for the most difficult case, maybe like a difficult CTO or a heavily calcified vessel. But as a workhorse guide catheter, I've actually started using that as my default guide.
Epicranial.
But I was just curious if other people had similar experiences. Anyone sitting in the front row here using Ikaris?
Ikari mostly for STEMIs because it allows you to do a complete angiogram before you engage with the culprit vessel intervention. But then I learned here this technique with the back of the wire, so I'm just using EBUs for STEMI, especially for the left coronary. If it's a right coronary, just go with the JR4. But I have not used for non-elective for elective cases. I haven't used the Ikari that much, and I dissected because sometimes when you try to do, perhaps it's my ineptitude, when you do the intubation of the right coronary, the maneuver ends up sometimes being a little bit abrupt. So I dissected the right coronary once or twice with the Ikari. So you have to be careful when you use it. And then it dives also very deep in the LAD.
I have not used actually Ikari, but said for acute MI I use Tiger Guide.
Are you ready?
It is very nice soft tip, and
when you're ready in a minute.
it does actually what we do, and we are using Tiger catheter routinely. It's very used to manipulating. Tiger Guide works great.
Let me
go a little distal.
Go in a bit.
In our center, we use extra backup routinely for left side cannulation, and if the left vein is short, then we use sometimes gel.
That's fine.
The left main
for right side gel, we use Dudkin's right.
Okay, good.
Mostly.
On that
but
subject,
we don't
can I
have
ask
the
about
good experience with Ikari.
And how about 5 French versus 6 French? With your
we use sometimes we use slender PCI with the type A lesions like that. It's very good, and it doesn't do any spasm in radial spasm, so it's very comfortable to do. We have done a couple of cases with 5 French. We don't have 4 French. I don't know about your experience.
No, we know in Japan they have the slender equipment. We don't yet have 4. Even 5, I say, is not commonly utilized in the US. I know Malcolm used a fair bit of 5 French for intervention, but most people still use 6 French. I think that's what the surveys show, Maurizio et al.
Can you take the circ wire out? It may give you selective cannulation LAD and better perfusion of contrast.
Okay. Just hold on 1 second.
Yeah.
But I just worry that this guy may be
Can we remove
not
this
too fan.
circ wire? No?
Yeah, I can.
Okay. Can you take it off? Wait.
Just test.
Just taste. Okay.
Okay, ready?
Yes. Yeah. Inject. This is good one.
Yes.
Come and check. Yeah, this is good.
You see a lot of calcium there.
Yeah, wonderful. So remove the minimal lumen area. This is, yes. Longitudinal view and the short axis view at the same time. So this parallel position is very wonderful. And here is some small branch. Here is the calcium, right? Yeah.
Mm-hmm.
Here you can identify the red color, but here might be the branch, yes. Yeah, branch, yes.
Looks good here.
Yeah, everything looks good, right? I try to again the distal portion. Yeah, no clot, no dissection, and here is a normal looking. You can identify the 3 layer, right, clearly, and the position is very wonderful in the distal portion, right here. So the landing zone in the distal is very nice. Here is a small branch. And calcium is here around 6 o'clock to the 3 to 6 o'clock. Also here the calcium. Someone misunderstand this might be the thin cap fibroadenoma, but you can identify clearly, delineate this portion.
Calcium.
This is a calcium.
Calcium, right?
Yeah.
Mm-hmm.
Here
Big calcium.
yeah. Intima, right? Small crack here, and here is the calcium. Just beside the calcium, you can sometimes identify a small crack like this.
Okay, no problem.
Some incomplete ablation, but the distance is
JY, the
acceptable.
the Y.
Opposite.
Here is a
Finish.
fibrolipidic.
After finish it, go into.
Here also the calcium here, and some branch.
Can we remove all this?
Yeah, this is a branch.
Just hold the Y.
Another branch here.
I need to make sure the left knee is okay. Looks okay.
It's also the branch. Yeah, so that might be okay. And here also the proximal side. No dissection, no crack. Only 2 thread is incomplete. It's okay, no problem.
So it looks good?
Professor, on the angiography, on the caudal view, in the proximal LED area, there was some excavation, looked like grade 1 kind of a perf.
Yeah.
No, there's a branch.
See that in the, like if you see the caudal view.
You might be this portion.
That portion, right?
Yeah.
Okay.
Right.
I don't like to hear the word perf.
Branch?
That's a branch.
Longitudinal we demonstrated some branch here.
There's a branch there, right? Okay. All right, are you guys happy? So
what I suggest is that we will ask TAC to cannulate right with the left Judkins, and once he cannulates, we will go off live, and we will go for disperse for the lunch. Just watch him cannulating the right with the left Judkins.
Strict LO.
LO.
And then we will break for the lunch, and then we will get together maybe by 2:15 or so.
Give me the stiff end.
The stiff end.
So using the stiff end, go into the JL35 to make the tip.
Yeah, convert it into JR.
Become JR. I learned these tips. I learned these tips from Dr. Patel many years ago.
So you have used the opposite end of the stiff wire, right?
So this looks like JR,
yeah,
right?
That's perfect.
So I just want to engage it and then get out here. Okay. All right, now the right cuff's better.
Yes.
Test it.
You just pull the wire back and you are in.
I think I'm in. Okay.
Yes, you are in. Excellent.
Take a picture.
TAC, is that okay? We disperse for the lunch now.
You want me to finish the case?
Yeah, you finish the case.
One through.
Okay, you want us to be live for?
No, you go for lunch.
Okay, fine.
I don't want you guys hungry.
So we will be getting.
Rajni,
Pardon?
Thank you so much.
Thank
for
you.
the case.
Thank you. So we are dispersing for the lunch, and after lunch we may get together by 2:15 for a very interactive session. Thank you.
Okay, so I want to do proximal part, right? Give me back the 2.5 balloon, 2.5 choke balloon, 2.5.
Previous one.
The previous 2.5.
2.5, 15, previous one.
Let me take out this one. Okay, good. The balloon ready? Always work. Always work. Okay. All right, go. So 3018 balloon should be right. Okay. 12 is fine. Okay, done. Picture. 3018. Okay, good. Let's do one more here. Get a 3018. Let's get high pressure because this one hopefully expand high 16. Okay, 25. No problem. It's only 25. All right, you had 3018 stand? Okay. I like that. When I go back, I'm using this one, this technique. Okay, got it. Okay, right? Picture. Okay, go, go. Go high. Yeah, 14, 16. It's good. Ready? I think we stop, no? Should be okay, right? Okay, thank you. Thank you very much, everyone. Thank you.